A very good morning to one and all. So I'm Dr. Savitri and I'll be presenting on topography guided removal of epithelium in keratoconus with cross-linking its 5-year outcomes. So at the outset, I would like to declare that me and my co-authors don't have any financial disclosure. So manual cross-linking has stood the test of time to arrest progression and is known to achieve stability. But at the same time, there is no improvement in visual acuity in many of the patients, and in many cases, we have to finally resort to rigid contact lenses for visual rehabilitation. But with the advent of laser-based cross-linking now, we can achieve both. So how do we go about this? Any patient having less vision and having a coma value of more than 1 micron is checked for the thinnest corneal thickness. If it is more than 450 microns, we can go ahead and plan a topography guided PRK treatment, which can be corneal or ocular wavefront guided. On the other hand, what if the TCT is less than 450 microns? What if the theoretical mean corneal thickness after ablation goes below 400 microns, or if the maximum stromal ablation exceeds 40 microns? If we plan a corneal or ocular wavefront guided treatment in such kind of corneas, we would lead to ablating a deeper layer of the stroma, and which will cause excessive scarring. So for such kind of eyes, we have devised a novel tissue sparing approach, which is known as topography guided removal of epithelium in keratoconus, that is TREC. So TREC essentially is a cyclotorsion compensated localized trans PTK, wherein PTK is performed at a depth of 15 to 20 microns along with the thinnest epithelial thickness. So how do we plan this? First of all, we localize the cone on the anterior tangential curvature map. Then we identify the long and the short axes. Then we perform a PTK over the area of thinnest pachymetry along with 15 to 20 microns of stromal ablation. Then manual removal of the epithelium around the cone area is done, which is followed by accelerated cross-linking. So here we can see that in the same eye, TREC is ablating lesser amount of stromal tissue. So what are the benefits that it offers? It gives a better abrasion profile. It regularizes the cornea. It ablates a very less amount of stroma. It gives improved visual quality and enhances the contact lens fit or the spectacle acceptance. So one would want to ask if it is comparable to TPRK. So yes, we found that at 1 year, both of them were doing very well and had improved visual acuity. But the TREC was shown to have lesser stromal tissue ablation. Does it also work in the long run? So to answer this question, we followed up about 78 eyes for a period of over 5 years. Patients ranging from 18 to 35 years were included. Keratoconus with decentered cones documented KC progression, thinnest pachy of less than 450 microns, and maximum planned stromal ablation of more than 40 microns were included. Whereas on the other hand, patients not willing for laser-based surgery, advanced KC with scarred corneas, and thinnest pachymetry exceeding 450 microns were excluded. So these patients were first imaged on Schwind MRS, and then TREC was planned for them. In the same sitting, accelerated cross-linking was done. So we used 0.1% riboflavin every 2 minutes for 20 minutes, which is followed by 9 milliwatt per centimeter square of UV exposure for next 10 minutes. So we found out that the efficacy index was 3.26. And coming to the safety part of it, so 40% of them gained 1 line after TREC and 55% of them showed no change. Sorry. The keratometry values were found to show statistical significant decrease. Coming to the astigmatism, so the refractive astigmatism, the mean was decreased from 4.54 to 4.55, but it was not found to be significant. The corneal astigmatism, though, was found to be statistically significant. Then change in the abrasion, so decrease in the lower and higher order abrasion was found to be statistically significant. Then does it make the cornea weaker? So as a part of our ongoing project, we imaged these corneas on pre-operative visit and then post-surgery on our polarization sensitive OCT. What we found out that the collagen in the central cone area was now more densely packed, and which was suggestive of an improved structural integrity of the collagen post-procedure. So these are few case examples which have shown flattening following TREC procedure. Coming to the complications, there was a progression in one eye out of the total 78 we had taken. There was loss of line of one line in 3% of cases, whereas there was no excessive flattening was not seen in any of the eyes. So what we knew from before was that TREC is an innovative technique which is useful in advanced keratoconus with thin, steep corneas, which is not amenable to regular laser-based cross-linking. It is a tissue-sparing technique which precludes scarring. The results are comparable to TPRK in the one-year outcome analysis that we had done before. What our study adds is that it is an innovative technique, and now it is showing good outcomes even with the 5-year data analysis. The efficacy has been proven now at the ultrastructure level in terms of the strengthening of the collagen, which was imaged on the polarization sensitive OCT. It's a novel technique to offer safer laser-based cross-linking for thinner corneas. Thank you. That's all from me.
What was the thinnest that you took in this?
So, ma'am, our main aim is that the stromal ablation should not go beyond 40. So, in TREC, it goes usually around 10 to 15. So, along with the epithelial thickness. So, what we do is we first image the epithelial thickness in the cone area. We take the lowest value, and then add the stromal ablation, which is around 10 to 15. So, our main aim is that after ablation, it should not go below 400. Or in some cases, 380 is also acceptable.
Any questions?
Thank you.
Okay.
Follow the treatment, you notice any scarring or any pains or anything?
No, sir, not at all. It's basically a PTK, sir. So it was not found, sir.